Hi, my name is Carissa Seaton. I am a physician assistant student at South University. Today I will be presenting my capstone project on screening and management of depression in adults. This presentation will focus on education of the screening process and implementing easy access to individuals with depression for treatment. First off, we have a content overview. First, I'll discuss a little bit about me and who I am. Then I'll give a little insight on the profession of a physician assistant. I will then discuss what Healthy People 2030 is and the significance behind the topic I chose. There will be a pre-quiz for discussion points, followed by depression overview, screening, and treatment. There will be a post-quiz on what was discussed throughout the presentation, and at the end there will be the conclusion and resources used for this presentation. As I mentioned before, my name is Carissa Seaton, and that is me and my school at the top. I was raised in Orlando, Florida, where I also attended undergrad at the University of Central Florida, obtaining a Bachelor's of Science in Health Sciences, with dreams of one day becoming a PA. I then worked as a scribe in the ED for a few years, then as an MA in the orthopedic surgeon's office for a few years, before getting accepted to PA school. I am now a second-year PA student at South University in West Palm Beach with intent on graduating in March 2023. I'm currently working under the guidance of Dr. Sugar for this project, who is our program director. I get asked this question a lot. What is a PA? It is still not as well known as some people may think, and I get asked almost daily what the title entails. A physician assistant, PA for short, with a new name of physician associate, to confuse people more, is a licensed clinician who practices medicine. PAs are educated at a master's degree level, and admissions are highly competitive, requiring a bachelor's degree and 2,000 plus hours of direct patient care prior to admission. PA programs are approximately 27 months, 3 academic years, and the occupation itself entails diagnosing, managing, treating illnesses, and they can serve as the principal healthcare provider. Here's a short video on what PAs are and what they do.
PAs are healthcare providers who practice medicine. They can help you get well and stay well. PAs can examine, diagnose, and treat you when you get sick or injured. They can interpret your lab tests, perform procedures, and assist in surgery. They also have the authority to prescribe medication. Most PAs complete a 3-year master's degree program that includes 2,000 hours in clinical rotations, but their training never stops. They complete 100 hours of medical education every 2 years and must pass a rigorous recertification exam every 10 years. On top of being nationally certified, PAs must be licensed to practice in their state. You'll find PAs in every medical specialty, from pediatrics to surgery, and every medical setting from hospitals to community health centers. America's PAs are dedicated to providing excellent care that focuses on the patient. PAs are proven to increase access to care, improve health outcomes, and elevate patient satisfaction. Visit aapa.org to learn more about PAs.
For our capstone projects, my cohort and I were supposed to choose a topic from Healthy People 2030 based on our interest to educate our communities. Healthy People identifies public health priorities to help individuals, organizations, and communities across the U.S. to improve health and well-being. Healthy People 2030, currently on its 5th decade, builds on knowledge gained over the first 4 decades. So, it provides 10-year measurable public health objectives and provides tools to track progress towards achieving them. Their vision is a society in which all people can achieve their full potential for health and well-being across the lifespan. Their mission is to promote, strengthen, and evaluate the nation's efforts to improve the health and well-being of all people. Pretty cool. So my Healthy People 2030 topic is under the Mental Health and Mental Health Disorders section. The goal is to increase the proportion of adults with depression who get treatment. The current baseline for those who got treatment in a year time frame was 64.8% in 2018. The most recent data shows an increase to 66.3% in 2019, and the goal is to bring that percentage up to 69.5 by 2030. So why depression? Good question, Carissa. I'm a huge advocate for all things mental health and the need to eliminate the stigma and openly talk about the daily struggles of life. I picked this topic due to my own personal history of depression and anxiety, and I know the difficulties behind seeking treatment. It's a multifactorial dilemma. There's a stigma, there's a lack of education in the community, there's difficulties with our U.S. healthcare system, there's the problem of recognizing the symptoms itself, and then that causing the delay of care and treatment. As a future provider, I hope to recognize mental health disorders, including depression, in any specialty I wind up in: pediatrics, gynecology, oncology, hematology, family medicine. It's everywhere. And as a provider, I hope to help these people. Here's the pre-quiz discussion questions that you can go ahead and answer along to. They are just simple questions to see your level of understanding of depression. The answers will be followed by each question, but the answers will also be further explained later in the presentation as well. Let's get started. Question 1. How is depression different from feeling sad? Okay, question 1 answer. Sadness is a common, normal human emotion. It occurs due to an event, but it still allows an individual to go about their daily activities. But if it's disproportional to those events and occurs over a significant period of time, sadness becomes pathological. Depression is a mental illness. It is a complex illness with a primary characteristic of mood disturbance. It can be due to a life event, genetics, or a combination of both. It can get in the way of work, relationships, and daily life. Question 2. True or false? Anyone can become depressed. Question 2 answer. True. Depression doesn't discriminate. Question 3. What are some ways to tell if someone is depressed? Question 3 answer. The DSM-5, the Diagnostic and Statistical Manual of Mental Disorders, the 5th edition, is a manual to guide licensed providers to diagnose mental health disorders. The signs and symptoms of depression according to this manual include persistent sadness, hopelessness, irritability, guilt, loss of interest, fatigue, difficulty sleeping or oversleeping, suicidal thoughts, suicidal attempts, physical pains, which we call somatic pains, headaches, cramps, etc., are all signs of depression, although not always obvious. Question 4. How do you get screened for depression? Question 4 answer. Multiple diagnostic screening tools are used depending on the population and the severity. The screening process is what is used to diagnose an individual with depression. Usually, the screening process includes one of these questionnaires, and the provider will also do blood work and a physical examination to make sure it's not due to any other medical conditions. These scales are typically given if you are showing signs or if you are seeking treatment. Some scales are used to assess the severity to guide treatment, while others may be given to assess if treatment is working adequately. These are examples of screening tools commonly used in practice. We have the PHQ-9 or the PHQ-2, which is also called Patient Health Questionnaire. We have the Beck Depression Inventory, the BDI. We have both the 5-item and the 15-item geriatric scale. And we have the Hamilton Depression Rating Scale. Okay, let's jump into the depression overview. So, what is depression? I'm going to play a quick video and let Ted Ed explain it because they can do it better than I can.
Depression is the leading cause of disability in the world. In the United States, close to 10% of adults struggle with depression. But because it's a mental illness, it can be a lot harder to understand than, say, high cholesterol. One major source of confusion is the difference between having depression and just feeling depressed. Almost everyone feels down from time to time. Getting a bad grade, losing a job, having an argument, even a rainy day can bring on feelings of sadness. Sometimes there's no trigger at all, it just pops up out of the blue. Then circumstances change, and those sad feelings disappear. Clinical depression is different. It's a medical disorder, and it won't go away just because you want it to. It lingers for at least 2 consecutive weeks and significantly interferes with one's ability to work, play, or love. Depression can have a lot of different symptoms: a low mood, loss of interest in things you'd normally enjoy, changes in appetite, feeling worthless or excessively guilty, sleeping either too much or too little, poor concentration, restlessness or slowness, loss of energy, or recurrent thoughts of suicide. If you have at least 5 of those symptoms, according to psychiatric guidelines, you qualify for a diagnosis of depression. And it's not just behavioral symptoms. Depression has physical manifestations inside the brain. First of all, there are changes that could be seen with the naked eye and X-ray vision. These include smaller frontal lobes and hippocampal volumes. On a more micro scale, depression is associated with a few things: the abnormal transmission or depletion of certain neurotransmitters, especially serotonin, norepinephrine, and dopamine, blunted circadian rhythms, or specific changes in the REM and slow wave parts of your sleep cycle, and hormone abnormalities, such as high cortisol and deregulation of thyroid hormones. But neuroscientists still don't have a complete picture of what causes depression. It seems to have to do with a complex interaction between genes and environment, but we don't have a diagnostic tool that can accurately predict where or when it will show up. And because depression symptoms are intangible, it's hard to know who might look fine but is actually struggling. According to the National Institute of Mental Health, it takes the average person suffering with a mental illness over 10 years to ask for help. But there are very effective treatments. Medications and therapy complement each other to boost brain chemicals. In extreme cases, electroconvulsive therapy, which is like a controlled seizure in the patient's brain, is also very helpful. Other promising treatments, like transcranial magnetic stimulation, are being investigated too. So if you know someone struggling with depression, encourage them, gently, to seek out some of these options. You might even offer to help with specific tasks, like looking up therapists in the area or making a list of questions to ask a doctor. To someone with depression, these first steps can seem insurmountable. If they feel guilty or ashamed, point out that depression is a medical condition, just like asthma or diabetes. It's not a weakness or a personality trait, and they shouldn't expect themselves to just get over it, any more than they could will themselves to get over a broken arm. If you haven't experienced depression yourself, avoid comparing it to times you've felt down. Comparing what they're experiencing to normal temporary feelings of sadness can make them feel guilty for struggling. Even just talking about depression openly can help. For example, research shows that asking someone about suicidal thoughts actually reduces their suicide risk. Open conversations about mental illness help erode stigma and make it easier for people to ask for help. And the more patients seek treatment, the more scientists will learn about depression, and the better the treatments will get.
There are a few classifications of depression depending on how and when the symptoms manifest and how long the symptoms last. There's major depressive disorder, also known as MDD, and this is when symptoms of depression last for at least 2 weeks and it interferes with one's ability to work, sleep, study, or eat. There's persistent depressive disorder, also known as dysthymia, which is a less severe form of MDD because it has less severe symptoms and lasts much longer, lasting at least 2 years. Then there's perinatal depression. That's when a woman experiences major depression during pregnancy. And then we have postpartum depression, when a woman experiences depression after delivery. There's seasonal affective disorder, which comes and goes with the seasons. Usually it starts in fall and early winter and ends by spring and summer. Then we have depression with symptoms of psychosis. And that's a severe form of depression where a person experiences psychosis. And these are basically symptoms of delusions and hallucinations. Risk factors for depression disorders include genetics, it is an inheritable disorder, brain chemistry imbalances, life events, abuse, medical conditions, diabetes, cancer, heart disease, chronic pain, stress, grief, or loss. All right, so here are some statistics of depression in adults. This is going to be both nationally and in Florida, where I currently go to school. Annually, the prevalence among U.S. adults with major depressive episodes is 8.4%. That's 21 million people. Suicide is the second leading cause of death among people aged 10 to 34. The risk of suicide is about 20 times greater among those diagnosed with major depressive disorder in comparison to those without major depressive disorder. Women are nearly twice as likely as men to have depression. The percentage of adults who experience any symptoms with depression was highest among ages 18 to 29. People with depression have a 40% higher risk of developing cardiovascular and metabolic diseases than those in the general population. And in Florida, 40.8% of adults reported symptoms of anxiety or depression. 24.8% were unable to get needed counseling or therapy. Floridians struggle to get the help they need. More than half of people with a mental health condition in the U.S. did not receive any treatment in the last year. Of the 796,000 adults in Florida who did not receive needed mental health care, almost 50% did not because of cost. 13.1% of people in the state are uninsured. Floridians are over 5 times more likely to be forced out of network for mental health care than for primary health care, making it more difficult to find care and less affordable due to higher out-of-pocket costs. 6 million people in Florida live in a community that does not have enough mental health care professionals. Statistics of screening and treatment. So this is why I wanted to do this project. These statistics show the lack of individuals seeking care and getting treatment. The average delay between the onset of mental illness, symptoms, and treatment is 11 years. 45% of U.S. adults with mental illness received treatment in 2020, leaving 55% untreated. 11% of U.S. adults with mental illness had no insurance coverage in 2020, and depression is the leading cause of disability worldwide. The highest proportion of moderately severe and severe depression results were highest among LGBTQ and students. So why are those with depression not getting treated? There are many reasons, and these steps can be difficult to overcome. There's the fear and shame. Some people still wholeheartedly believe mental health issues equates to weakness. Having to overcome this stigma and discrimination can impact an individual's mental health greatly. Limited awareness. This is why education is so very important. Some people will blow off or minimize their symptoms. Education can allow individuals or those around them to identify concerning symptoms. There's the distrust in the medical field. There's the unavailability. Some people don't know where to find help. And that is also why education comes in handy, because educating anyone and everyone who will listen on where they can access care. There's the physical barriers, which ranges widely from financial reasons to scheduling difficulties to transportation issues. 1 in 3 individuals who do get screened report they do not plan to take any further action after the screening. That's what we need to fix. How can we make the Healthy People 2030 goal a reality? Access, access, access. Making screening tools accessible to everyone will allow individuals to be diagnosed and treated. Educating individuals that these tools exist is so very important. These tools will allow patients, individuals, people around the nation to learn what mental illnesses are, what to look out for not only themselves, but for others. Also, increasing screening processes in all specialties is something that the providers, us, in the future, will have to do. Screening improves the chances of getting treatment. Primary care physicians providing usual care miss 30 to 50% of depressed patients and likely fail to recognize many common mental health disorders. However, when they do have a positive screening test, they are more likely to recognize the symptoms and have a good follow-up plan for their mental health disorders. Access to screening. There is quite a bit of tools that can be used online to screen for depression. There is no best website, but Mental Health America is one of my personal favorites. This is due to diverse mental disorders that can be screened with proper follow-up, along with the easiness of navigating the site. MHA provides individuals with free, anonymous, and confidential screening tools that allows people to explore their mental health concerns and brings results straight to a provider. The site uses scientifically validated screening tools, and these are the same tools we previously discussed in the pre-quiz. So for depression, it uses the PHQ-9, and that is the same questionnaire that providers use when you go to the doctor's office. I'm going to go ahead and navigate through this site with you just so you can see the easiness and what kind of questions the questionnaire entails. So this is the Mental Health America website. You can use this link and put it in your browser to get to this exact location, or you can Google it. You can take multiple mental health tests ranging from depression, anxiety, postpartum, psychosis, eating disorders. They have options of taking it in a different language. They also have the option of a parent taking it for concerns of a child mental health. But of course, we're going to be doing depression. This is the PHQ-9. What it states is, over the last 2 weeks, how have you been bothered by any of the problems? These answers are not going to be pertained to how I feel. These are just an example. 1. Little interest or pleasure in doing things. 2. Feeling down, depressed, or hopeless. 3. Trouble falling asleep or staying asleep. 4. Feeling tired or having little energy. 5. Poor appetite or overeating. 6. Feeling bad about yourself or that you're a failure and have let you or your family down. 7. Trouble concentrating on things such as reading the newspaper or watching television. 8. Moving or speaking so slowly that other people have noticed. 9. Thoughts that you would be better off dead or hurting yourself. 10. If you checked any of these problems, how difficult have these problems made it for you at work, home, or with other people? This is just a demographic. You can put information about yourself, or you can choose to skip it like I am here. And the results showed moderately severe depression on the answers I gave. And it does give you a warning that my responses indicate that I am at risk for harming myself, and it gives me resources to contact somebody for help. So this is the PHQ-9 scoring interpretation. This is just a chart showing the PHQ-9 score and then the depression severity based on that number. This is just for your information, so if you got a number score, you can know what that means and what typically the treatment actions would be. Although I wouldn't follow this on your own, I would always get a medical professional to assess and treat you based off of your score. Okay, now that screening is complete, what now? Treatment. Depression is very treatable, with the majority of those who seek treatment showing improvement. The most commonly used treatments are antidepressant medications, psychotherapy, or a combination of both. The choice of treatment depends on the pattern, severity, persistence of depressive symptoms, and the history of the illness. As with many illnesses, early treatment is more effective and helps prevent the likelihood of a serious reoccurrence. To further explain how we treat depression, I'm going to play another video for you guys.
In the 1950s, the discovery of two new drugs sparked what would become a multi-billion-dollar market for antidepressants. Neither drug was intended to treat depression at all. In fact, at the time, many doctors and scientists believed psychotherapy was the only approach to treating depression. The decades-long journey of discovery that followed revolutionized our understanding of depression and raised questions we hadn't considered before. One of those first two antidepressant drugs was iproniazid, which was intended to treat tuberculosis. In a 1952 trial, it not only treated tuberculosis, it also improved the moods of patients who had previously been diagnosed with depression. In 1956, a Swiss clinician observed a similar effect when running a trial for imipramine, a drug for allergic reactions. Both drugs affected a class of neurotransmitters called monoamines. The discovery of these antidepressant drugs gave rise to the chemical imbalance theory, the idea that depression is caused by having insufficient monoamines in the brain's synapses. Iproniazid, imipramine, and other drugs like them were thought to restore that balance by increasing the availability of monoamines in the brain. These drugs targeted several different monoamines, each of which acted on a wide range of receptors in the brain. This often meant a lot of side effects, including headaches, grogginess, and cognitive impairments, including difficulty with memory, thinking, and judgment. Hoping to make the drugs more targeted and reduce side effects, scientists began studying existing antidepressants to figure out which specific monoamines were most associated with improvements in depression. In the 1970s, several different researchers converged on an answer. The most effective antidepressants all seemed to act on one monoamine called serotonin. This discovery led to the production of fluoxetine, or Prozac, in 1988. It was the first of a new class of drugs called selective serotonin reuptake inhibitors, or SSRIs, which block the reabsorption of serotonin, leaving more available in the brain. Prozac worked well and had fewer side effects than older, less targeted antidepressants. The makers of Prozac also worked to market the drug by raising awareness of the dangers of depression to both the public and the medical community. More people came to see depression as a disease caused by mechanisms beyond an individual's control, which reduced the culture of blame and stigmatization surrounding depression, and more people sought help. In the 1990s, the number of people being treated for depression skyrocketed. Psychotherapy and other treatments fell by the wayside, and most people were treated solely with antidepressant drugs. Since then, we've developed a more nuanced view of how to treat depression and of what causes it. Not everyone with depression responds to SSRIs like Prozac. Some respond better to drugs that act on other neurotransmitters, or don't respond to medication at all. For many, a combination of psychotherapy and antidepressant drugs is more effective than either alone. We're also not sure why antidepressants work the way they do. They change monoamine levels within a few hours of taking the medication, but patients usually don't feel the benefit until weeks later. And after they stop taking antidepressants, some patients never experience depression again, while others relapse. We now recognize that we don't know what causes depression or why antidepressants work. The chemical imbalance theory is at best an incomplete explanation. It can't be a coincidence that almost all the antidepressants happen to act on serotonin, but that doesn't mean serotonin deficiency is the cause of depression. If that sounds odd, consider a more straightforward example. Steroid creams can treat rashes caused by poison ivy. The fact that they work doesn't mean steroid deficiency was the cause of the rash. We still have a ways to go in terms of understanding this disease. Fortunately, in the meantime, we have effective tools to treat it. Depression affects almost 10% of adults in the United States. Learn more about symptoms, treatments, and how to help a struggling friend with this video.
So in conclusion, the goal of my capstone project is to increase the number of adults with depression who get treatment by educating individuals on how to obtain easy access to proper screening tools. The learning objectives are simple. What is depression, the signs and symptoms of it, the different types, the screening tools used, how to access those tools, how to navigate those tools, and the common treatments used to treat depression once an individual is screened. So these are just some post-quiz questions you can go ahead and answer. I won't be giving an answer because we already discussed them in the presentation. You can go ahead and skip this if you would like to skip the questions, and then that will be the end of my presentation. And that concludes my presentation. Thank you so much for listening. I hope you guys learned something. If you didn't, I'm sorry. Please share what you've learned with others. It will always help when it comes to depression. Thank you again.